Brief comment on Australian Rotary Health is it's one of the largest independent funders of mental health research within Australia. And through Australian Rotary Health primarily provides funding into these areas of health that may not readily attract funding. They also play a significant role in spreading awareness of mental health issues through Lift the Lid on Mental Illness campaign, which more about that later. So today it's my pleasure to introduce James Martin, and he is a recipient of the Ian Scott Mental Health PhD Scholarship Award. And a little bit about that. Ian Scott joined Rotary in 1973 in Victoria and served with distinction in many Rotary clubs throughout New South Wales and Victoria. Whilst a member of the Rotary Club of Mornington in Victoria, Ian was inspired to found Australian Rotary Health, and in 1981 to identify the cause of cot death, which has been a wonderful thing for him to do. Ian's scholarship was introduced in 2000 to honour and recognise Ian's service to Rotary and mankind. Now, on to James. James is completing a Doctor of Philosophy in Medicine at the University of Adelaide in the discipline of psychiatry, focused on neurobiology of schizophrenia and early psychosis. He is also legally qualified psychologist, registered with the General Registration with the Australian Health Practitioner Regulation Agency. He obtained a first-class Bachelor of Science with honours psychiatry at the University of Derby in the United Kingdom, where he was awarded the Undergraduate Research Scholarship Scheme and co-authored his first publication on the topic of critical thinking. He then completed the 2-year AHPRA internship and further training to obtain his registration as a psychologist in Australia. So I introduce James now, and I'm sure you'll find his talk most interesting, and hopefully he'll be able to come back when he's completed it to see if his thesis actually worked out. Thanks, James. We'll come back about 2 minutes before.
Thanks, Kay. Thank you very much. Appreciate that. All right, let me see if I can get everything working to start with. And thanks, Trevor, for acknowledgement to country. So as Kay mentioned, she's already introduced me, which is great, so that saves me doing this. As she's mentioned, I'm a legally qualified psychologist by background, doing my PhD in medicine on schizophrenia. I also work in private practice at the moment, so primarily in therapy services and writing medical legal reports for forensic mental health as well. So that's pretty much where I'm spending my time, and I'm going to talk to you a bit today about schizophrenia and self. Hopefully, you can hear me a little bit better there. Okay. So, as I said, today I'm going to talk to you about schizophrenia and self. I want to start by defining self and defining schizophrenia and how those two things relate. And then we're going to talk a little bit about the problem of co-occurring mental illness and ways that we screen for schizophrenia in Australia and how some of our research is linking to that. So let's start by defining self. You would think self is something that should be relatively self-evident, but I'd like to say that maybe it isn't. We're going to make a distinction here between what we call two levels of self. When I say self, you probably have an idea in your mind of what I'm talking about, and that is commonly what we call our self-identity. It's a list of features, it's a list of traits that we have, and that refers to that top level there, the narrative self. So if I asked you who you are, you might say something like, I'm a father, I'm a business owner, a psychologist, those sorts of things. What you probably wouldn't say is, I'm the mover of my right arm, or the owner of my left toe. And I'd be a little worried if you did tell me that. And that's because those things are part of what we call the basic self, a deeper layer of self that seems to be self-evident, unquestioned. Okay? And that's a distinction I want to make here. And I'm hoping that that gets you thinking a little bit, but I'm also going to tell you a little bit of a story that might get you thinking a little bit more about self. So, true story. 3 weeks ago, I was walking along the street in Adelaide CBD, and all of a sudden, got this really strange, uncomfortable feeling like I was naked. And That's not a very nice thing to think when you're in the middle of the street. And so, of course, I look down and get a huge sense of relief that I'm not naked, I'm actually wearing clothes. But what I did feel is this sense of vulnerability, like something was missing, okay? And after a few seconds, I realized, strangely, not wearing my wedding band, not wearing my watch, and as soon as I realized that, that feeling goes away. Lasted only a few seconds. Most people probably wouldn't recognize it. Me being the weird person that I am, did recognize it. But it got me thinking, has this wedding band and this watch, these pieces of jewelry, become sort of so part of me that when I don't wear them, they actually feels weird? It feels like I'm missing something or missing a part of myself. And so I started thinking a little bit about, well, what are some of these changes to that really deep sense of self? Not the list of traits and features, not our jobs, our roles, those sorts of things, but actually who we are and how we define what is us and what isn't us. And the first thing that popped up into my mind is something called phantom limb syndrome, which you may have heard about, you may not have. But what it refers to is when somebody has an amputation, they often get a sense afterwards that the limb is still there. They can feel it, they can sense it, and they can actually experience pain from it as well. So I thought, well, okay, that's something missing. That makes sense. The brain needs to adjust. What about if something's gained? So I started looking into organ donation recipients. And there's actually a long literature of these weird bodily symptoms in people who've received organs. And this is just one example. Somebody described feeling attacks of anxiety, a fear of death, ran out in the corridors totally wrecked. I couldn't find me. Who am I? Where do I come from? It was like the familiar me, but the safety I had felt was no longer there. Instead, there was a new person. This is somebody who had a heart transplant. Strange. And what happens often in these situations is our brain is adjusting to minimize the discrepancy between what we believe objectively, what we can see to be true, and what the deep underlying part of our brain still believes is true. Okay? The model of ourself that we've built up over many, many, many years all of a sudden changes overnight. And it takes time for our brain to adjust to that. And most of the time it does, and these feelings go away. But what happens if that doesn't occur? What happens if that mechanism that allows the brain to minimize that gap between what is true and what we still believe deep down, what if that goes haywire? What if we begin to feel things that can't be explained by a new organ or a missing limb or a forgotten wedding band? What if our sensations can't be attributed to something obvious? Well, what happens then? And this kind of brings me on to schizophrenia, because what we do believe is that these sensations, these differences, when that goes haywire, is actually a core feature of schizophrenia. So I'm going to talk to you a little bit about schizophrenia. What is it? It's a lifelong condition. Generally becomes prominent in adolescence, often leads to lifelong impairment, affects about 1% of people worldwide. It doesn't seem to differ too much across countries or across cultures. Makes a person 3 times more likely to die young. 50% of people detained in psychiatric hospitals worldwide have a diagnosis of schizophrenia. And it costs Australia approximately $2 to $3 billion a year to manage, treat, and support in terms of economic and social costs. It constitutes about 5 to 7% of incarcerated adults in Australia, despite the fact that people with schizophrenia are far more likely to be victims than they are perpetrators. So that's a little bit about schizophrenia. And when we think of schizophrenia, you'll have seen the common iceberg analogy. We often think about these things at the top, the things that can be seen from the outside. Hallucinations, seeing things that aren't there. Delusions, believing things that aren't true. And disorganized behavior, that unpredictability that you can sometimes see in somebody with schizophrenia or a psychotic episode. But underneath all of that, the things that you can't see, the things that are happening on the inside, are these changes in self, that deep sense of self. Changes in first-person perspective, changes in our sense of agency, changes in the way we see the world, whether the world looks real, how attached or connected we feel to the world. Those are the things that are much harder to see on the surface and much harder, particularly for doctors and clinicians, to recognize in their patients. They also tend to be quite hard for patients to describe in words and put into words. The reason we think this is important to understand these things is because schizophrenia and psychosis happens as a process. And you can see it there on the right there. Those experiences on the outside, those hallucinations, those delusions, they really refer just to that little bit that says psychosis on the right of the screen there. But before that, there's a lot going on. There seems to be this emerging pattern of an increase or a steady increase in those underlying symptoms that we call the prodromal phase. And those prodromal symptoms are all of those things underneath that are very hard to detect, but that predict when someone's going to become unwell. It would be useful for us to be able to detect some of those things before someone becomes unwell, before someone requires hospitalization, before someone does something that might get them into legal trouble. And often, if we can prevent an episode of psychosis, that person's chance of regaining their prior functioning or maintaining their prior functioning improves dramatically. So why, aside from what I've just explained, why is this my topic for my PhD? Why am I so interested in this? I think if we look at a history of schizophrenia, and we look at the timeline of what we understand about schizophrenia, if we look in reverse order and we look at schizophrenia today, what we see is our diagnostic criteria that focuses primarily, if not only, on those symptoms on the outside. The delusions, the hallucinations, the disorganization. Those things, very important for diagnosing schizophrenia, but often rely on the person already being quite unwell. There's very little mention of self in any of the diagnostic criteria for schizophrenia. But if we go back in time to the people who actually gave us the term schizophrenia, who developed the symptoms of schizophrenia, who first formulated this as a mental illness, the prominent psychiatrists sort of prior to the 1950s, what you actually just find is that all they talk about is self. Kraepelin talked about a splitting of self-awareness, of self-consciousness, an ego disorder, which ego referred to the self back then, a disturbance of the innermost structure of the self, a lowering of the barrier between self and the surrounding world, a loss of the very contours of the self. We seem to have lost this idea that self is part of schizophrenia, and that's something that our research or emerging research is starting to suggest we need to replace into our understanding of schizophrenia. So to give you a little bit of a pragmatic or practical understanding, these are some of the things that patients have told me just in the last couple of months. And I want you to take a glance at them, have a look through, and see whether you can see that link to self, to that really deep sense of self, or a loss or disturbance of that deep sense of self. When I look in the mirror, I often wonder, am I the real me, or is it the reflection the real me? Sometimes I feel disconnected from the world, like I'm trapped in an invisible box between me and everything else. My thoughts feel like they can be available to others or can be blocked. A patient told me just last month, the voices in my head are constantly arguing and abusive. I try to be the peacemaker, but I can't do anything because I can't keep them all happy. And what this tells us is, in schizophrenia, this disturbance of basic self, or this disturbance of this really deep sense of self, is a core feature of schizophrenia. In the research, we've got meta-analyses and systematic reviews of decades of research now suggesting that this clusters in schizophrenia and isn't just a general part of mental illness. It occurs only in schizophrenia. So we started asking ourselves the question, well, given that this journey to psychosis is a journey, it's a process, is it going to be useful to try and capture these self-disturbances in young people, and particularly young people who are invulnerable to psychosis? And this brings up the first of our problems, the problem of co-occurring mental illness. In Australia, the way that, and in much of the world, and particularly the developed world, the way that we try to treat schizophrenia is by screening for people who are vulnerable for a psychotic episode, and then providing them treatment prior to, in order to prevent it. The problem with that is that it screens positive lots of people with lots of co-occurring mental illnesses, and it's not so simple to actually identify schizophrenia or any of those mental illnesses within that group. And what we found when we started looking was lots of research articles struggling to tell the difference between all of these diagnoses. And in Adelaide in specifically, we actually looked at the early psychosis service in Adelaide, where everyone at risk of psychosis in South Australia is streamed into. And what we found was that within the caseloads of all the clinicians in Headspace Adelaide, the early psychosis service, they had 50% or almost 50% of young people had confirmed and suspected neurodiversity. So that's autism, ADHD, sensory processing disorders. It's very difficult to tell these different disorders apart, these different diagnoses apart. And as you can see there, there's a large number of people there with dual diagnoses, with intellectual disabilities. And this was just last year. So what we started doing was looking into whether it would be useful to use these experiences of self to try to understand which people might respond better to which treatments within an early psychosis service. And what we found, we published this just this year, what we found was that basic symptoms, these disturbances of self, can actually inform diagnoses and treatment. We found that in young people at risk for psychoses, these symptoms were twice as likely in those with schizophrenia-related diagnoses, but they weren't associated with any of the other pathology, despite the fact that these people had screened positive for being at risk for psychosis. We then found that those people who had endorsed those symptoms of self were far more likely to transition to psychosis in the next 2 years. So what we concluded was that the basic self does cluster in schizophrenia, and it predicts a higher likelihood of transition to psychosis. These are the people within those groups that need maybe not the most help, but certainly a specific treatment, specific interventions. So one of the other questions that we're trying to answer at the moment is, how does this disordered self-consciousness, these problems with our sense of self, how do they occur, and what can we do to actually improve clinical services? Well, we published a review just last year suggesting that there's actually an issue with the brain networks within schizophrenia that might be specific to schizophrenia that might underlie some of these experiences. You can see there, and I'm not going to go into this in too much detail, but these 3 distinct networks in the brain. On the left there is our default mode network. That's our self-reflection network. When we're not paying attention to anything, we're reflecting. That's the one that's active. When we try to solve a problem, when we notice something in our environment that needs to be solved, we flip to the one on the right, the central executive network. That's our frontal network. It's the one that we use to solve problems. And the salience network, that blue one in the middle, that seems to be the switch. It seems to be the one that switches between the problem-solving network and our reflective network. In schizophrenia, we think that the salience network goes haywire a little bit. It struggles to switch the networks correctly. It doesn't recognize when it needs to switch on and off the problem-solving network. And so it ends up switching them both on at the same time. When in most healthy people, you would switch the reflective network on, off, and the problem-solving network on, and vice versa. So we're trying to test that hypothesis at the moment. And one of the ways we're doing that is with electroencephalography. You can see there on the left, the EEG requires a cap with electrodes that you put on somebody's head. And we use that cap to pick up on people's brain signals, brain waves, and then we sort of reverse engineer that to map out their brain and see where different signals are coming from within different parts of the brain. And through that, we can reconstruct a person's brain and try to understand whether the switch, the region of the brain that does the switching mechanism is the one that's impaired. So that's one of the things we're doing at the moment that we're recruiting for and currently actively recruiting from the Adelaide site. The way that we tend to understand how the brain is connected when we are trying to reconstruct it is we want to see which regions of the brain are connected together. It's normal to have parts of the brain firing in synchrony and parts of the brain that fire out of synchrony. When something fires in synchrony, when they're firing at the same time, two different parts of the brain, you assume that those two parts are connected, and that means that those two regions are actually connected together. There's a link between them. When they're firing out of sync, then there's no link between them. Okay? So when we are looking at these different networks in the brain, what we're looking at really is whether the signals are firing in the right times, in the right patterns, in the right places. And the idea here is that in schizophrenia, those signals will be firing out of pattern in a very distinct part of the brain. Another thing we're trying to do is look at novel ways of screening for psychosis. And particularly, I think this is relevant in an Australian context where we have a lot of people who live in rural areas who can't access specialist services, medical services, or find it difficult to access medical services. At the moment, they're having to travel long distances. Often they can't get referrals. And this is one of the big problems in particularly in early psychosis and schizophrenia. It's particularly a problem because schizophrenia requires quite a lot of clinical judgment. It requires quite a lot of experience to diagnose. And so it's not usually as easily diagnosed through telehealth, through self-report measures. It often requires sitting in front of quite an experienced psychiatrist or psychologist, or both. So what we're looking at is finding novel ways to screen for it, to inform our understanding of it, and one of the ways we're doing that is with digital biomarkers. Now, you've probably heard of things like genetics and DNA as a way of screening for psychosis. But with digital biomarkers, we're picking up on people's facial features and acoustic features, the features of their voice, to try to understand whether there are patterns that are specific to schizophrenia. So you can see here, this is one of the signals that you would see in somebody's voice, and on this one here, that's picking up on different landmarks of their face to see if there are distinct patterns that we can that are specific to schizophrenia. So these are a couple of the things that we're doing at the moment to try to improve screening and our understanding of schizophrenia and the self in particular. And that's me, so thank you very much for your time. And sorry, just before I'd like to go, I would like to thank Australian Rotary Health for the Ian Scott Scholarship and allowing me to, I guess, do the things that I really like to do. Yes, if you have questions, jump in.
So, thank you very much for that. It was very, very interesting. So I take it from what you're saying, its root cause is some malfunction in the way the brain's operating, presumably from birth. Is there a nurture side to schizophrenia, or is it all sort of nature?
So like most things, it's never one nor the other. What we do see is more evidence that this can be. There's a good argument at the moment that this is a neurodevelopmental disorder, that schizophrenia is a neurodevelopmental disorder. Now, the route into the symptoms of schizophrenia is very complicated. There's a lot of routes into it. What we are starting to see is that these experiences can be detected very young, very early in childhood, that they tend to heighten around adolescence or around times of trauma or stress, and that those things can then trigger a psychotic episode, and usually once that psychotic episode occurs, that person's very vulnerable to it reoccurring, and those symptoms tend to stick around afterwards.
Just one more question.
Thank you so much for an absolutely fascinating presentation. Just wanted to ask, in terms of the participants for your study, do they all have to be young people?
So at the moment we're recruiting between the ages of 12 and 35, so not all young people, but we're trying to capture what is essentially the criteria for early psychosis, which is as young as 12. The symptoms that we're looking for, these experiences of self, as you can imagine, are quite hard for young people to express, to put into words. That's part of the difficulty. In fact, they're very hard for adults to put into words. Under the age of about 8, you can't really reliably detect these symptoms, and even arguably up until about age 10 to 12. The part of the problem with that is that a lot of children have very magical thoughts, and so it's very difficult to differentiate between what's just typical thinking pattern of a child versus what might be reflective of something that's quite unusual or a disturbance of their subjectivity.
Just one more, Jeff.
Not on.
Is it on now?
Yeah.
Yep. Thank you. My question was actually, I heard the question for nature nurture, but what's the role of illicit drugs in this diagnostic pathway, or actually it end up to schizophrenia?
So this is, I guess, where we try to some degree, try to separate psychosis from schizophrenia. Psychosis is very much an acute episode that is characterized by this detachment from reality, the hallucinations and delusions that you see. Drug-induced psychosis is extremely common. I did mention earlier that although we do see this as somewhat of a neurodevelopmental journey or pathway for schizophrenia, it can certainly be exacerbated by trauma, by head injuries, by drugs. And often what you tend to find is that can often trigger a psychosis, but with schizophrenia, what you would find is that prior to the drugs, you would still detect some of these unusual disturbances of self that the person may have really not been affected by throughout their whole life, but they would have been there, and you'd be able to detect them. Whereas in other forms of drug-induced psychosis, that person wouldn't have experienced any of these experiences of disturbed subjectivity prior to, but the psychosis was still caused by the drugs. So it's often a matter of looking at the life trajectory to try to tell the difference. But yes, absolutely, drugs can certainly impact the brain and will cause a psychosis, but not necessarily schizophrenia.
I'm sorry, we have to finish there. And in finishing and thanking James, I'd like to present you with this banner, especially for our guest speaker, in appreciation. And all monies raised today will go to Australian Rotary Health, as I understand. And so thank you again, and I ask members to stand and thank you.